Hello and welcome to the Safety and Quality Education Program podcast. Developed by Metro North Health Safety and Quality in partnership with the Clinical Skills Development Service, Metro North Health acknowledges the traditional custodians of the land upon we live, work and walk, and pay our respects to elders past, present and emerging. The Safety and Quality Education Program has been designed with a focus on patient safety improvement. Each episode will explore ideas and stories in making our care delivery safer for our patients through the implementation of short notice accreditation. Our host is Dr. Mia McLanders, who is the Manager of Research at Clinical Skills Development Service. Mia is an applied researcher with a background in human factors and cognitive psychology. Joining Mia on this episode from Metro North Health is Dr. Joel DeHunty and Belinda Barry. Joel is a specialist medical administrator and Director of Research at Redcliffe Hospital. He co-chairs the Redcliffe Hospital Standard 6 Communicating for Safety Committee. Belinda Barry is a consumer representative on the Metro North Standard 6 Communicating for Safety Committee. Belinda cared for her husband for 12 years before he passed away in late 2021. He was a frequent patient in the cancer care and transplant unit at Royal Brisbane Hospital. In this episode, our guests explore community safety.
Joel, what clinical spaces do you find yourself in now?
So my training was in largely in emergency medicine and in ICU, but at a point I made a decision to go down a medical administration pathway. And to a large extent, that is one step off the ward or the clinical environment, and it's often supporting clinicians is a big part of my role. When do I get involved in clinical matters? It is actually when I'm on call. We have something called Ryan's Rule. When patients need to escalate something, that's a point that I get involved, or whether there are concerns or complaints. It's often some of the more challenging, difficult things that I tend to get involved in as part of my medical administration role.
So how did you two end up on the Standards Committee?
They put out an expression of interest and on the standards committees, and I had been involved with Westmoreton on the standards, and so I went, yeah, fine, and I ended up on two committees, so Standard 6 and Standard 8. So what can I do to help in future, or how can my voice be heard better or louder to say, you know, we've done 11 years, you know, I know his condition and I know him better than anybody, but I wasn't heard that day. And yes, okay, it wasn't a person's fault. It was a failure of a whole system, basically, because they were under such a load of pressure and there was so much going on that day and understaffing. But even so, had I been listened to, we would not have had John go to that degree, and he would have stayed stable. We actually came in early for the first time ever with an infection in 11 years. And that was the worst day that he nearly died. So
I'm so sorry.
Yeah, so it was quite traumatic. I ended up having to have a lot of counselling after that one. I got some PTSD from that. I ended up with a horrible fear of the ED, which I'd never had before. The next time I had to come in, I went into a full-blown panic attack, which I'd never had before. So it wasn't just what happened to him, it was also what happened to me. And I do this consumer engagement because I want to help the people who are coming after us. And John and I said in the very beginning that we would be involved in trials, research, anything that could help others coming after us, no matter what the outcome was for us. So that's why I do it.
That's very generous of you.
I enjoy it now.
That's good.
Yeah.
Joel, that's really hard to hear, isn't it?
Yes, it is.
Yeah.
But I guess I hear how important communication is in everything we do. You asked, how did we get involved in communicating for safety? And I don't know. I think we were dividing up portfolios, and I managed to get assigned to this committee, and I am so glad of that, because when I think about communicating for safety, it's links to every single thing that we do in healthcare, whatever your role, whatever your position. It's fundamental to what we do every day of the week, all day, every day, and I think this standard is unique in that regard, and I think that idea that we are as a team is a really important message when we delve into this topic. So it's great to be part of the Communicating for Safety team.
Yeah. I don't want to play favourites, but I think we just did, right? Like, I think this standard is...
It's my favourite.
It's right up there, isn't it?
It is, yeah.
What do you think, Joel, in terms of the difference between, the cyclical sort of every 3-year kind of accreditation compared to the short notice accreditation that will improve patient outcomes?
The thing about short notice accreditation is that it can happen anytime. And the accreditors are coming to see how does the rubber hit the road. So this is not a special event that we prepare for. This is looking at what do we do every day. And I think that's a really important point about short notice accreditation. So it's taking away this preparation for an exam kind of feeling to say, what should we be doing? How do we live best practice all the time, every time? And for communicating for safety, that is so important. It's around the patient identification. It's about staff introducing themselves and their role. It's about handing over key information, checking understanding. It's linked to every single thing we do, from the front door of the hospital, patient coming in for an elective surgery, coming into emergency department. It's about the teamwork to say clinical handover is not just for clinicians. Clinical handover is for all staff. It's clinical handover involves the patient, family and carer. And that's a powerful message that we need to demonstrate all the time. And accreditors, I think the accreditation process is important because it gives us an external validation to say, are we doing what we say we do?
So I think that's what you're saying, is to sort of do a litmus test or a check on what our consistent habits are, not our every now and then habits. A bit like, our gym attendance, right? It's what we do consistently is what matters most.
I think another really important thing about the accreditation process, it's increasingly people-focused as opposed to document-focused.
Oh, interesting.
So the accreditors are coming in, they're following the patient journey. They're going to go to all of those handover meetings, those shift-to-shift, those bedside handovers, those multidisciplinary handovers, and they're going to see they're going to observe what's actually happening. And so it is looking at what is the culture, what is the practice of our hospital, our staff every day.
Joel, when have you seen the handover done well in a clinical environment?
There are some elements that we know are essential to communicating for safety, but there's another layer on top of it, and Belinda's touched on this with her story earlier, which is about that respect and care. We can't communicate for safety without having that respect and care, but we know there are some elements that we've got to include. So that's around ensuring that I'm introducing who I am and what my role is to someone that I may patient, family that I haven't met before, so they know who, and that's a really important part of making it a caring environment. In terms of the clinical handover, it's about communicating information that could be quite technical or could have a lot of information in a succinct, so having structure around how you communicate. And one of the tools that we use in a clinical environment is SBAR, so situation, background, assessment, response. as a team, if we know how we are communicating, we can tune into the key elements of it a lot better than a discussion that may be rambling. So good communication for safety has some structure. It's got some core elements around identification, self-identification, patient identification, so in bedside handover, involving the patient at the bedside. They are part of the handover process, checking in. And a key part of it is actually checking that the information that's been handed over has been received. So that check back process to say, do you have any questions? And allowing opportunity for confirmation that message has been received. So there's some elements that when I see that, and I'm involved in audits as part of our safety and quality process, when I see things like that, I see that there is good leadership of handover. I can see that there's structure. I can see that patient identification is occurring, that patients are involved. They're all tick, tick, tick for me that I say this is a good handover.
That's excellent. Belinda, what's it like from a consumer point of view, the difference between, a handover that involves you as a carer and consumer versus one where you're not involved or excluded from that handover?
One of the things I fought hard for as carers, particularly, and patients, but carers, to be involved in the handover, particularly in our chronic illness, and also with my mother now with dementia as well. Quite often she gets told stuff at the bedside and I'm not told. Mum doesn't remember it, or she confuses it, gets it mucked up. The assessments that have been done, like for my mother, for example, she can be assessed by the physio for her ability to transfer and those sort of things. So if I'm not told before I take that person home about these changes or these things, and I get home, I don't have a discharge summary yet because it hasn't been printed up, and I'm then flying with what I've got. I am a part of that care team as a carer, and a very integral part of that care team. I get them to hospital when they're sick. I identify when things are going wrong. I sit with them in emergency and call out when I notice deterioration or something that's different. I know a lot about that person. I've been caring for them a long time.
Jill, I want to hear more about your experiences though, like personally. You've seen a lot, right? You've been involved in accreditation and you've been around the traps for a while now, and I want to hear your thoughts about when you walk into a clinical space and you see the communicating for safety attributes are really well exemplified versus not really. You're not necessarily going to see them as much in this particular environment. What's the difference from your point of view and in your experience?
It's a really good question. But the effectiveness also comes down, or the subtle things are all the day-to-day things. So we've got clinical staff who are checking medications. They're administering medications, and the patient checking patient's name, date of birth, armband, and all of those steps are all our safety mechanisms in all of those steps along those processes. Request forms, not rushing to do a request form and making sure that the information you're putting on there is correct, the right patient, those samples are labelled correctly. All of those things are so significant, and you can say, there are all these little jobs that we're doing, but they're all very important to do correctly all the time. I remember back as a junior doctor, I think you come out of medical school and you have the scientific knowledge, or you think you do. You've got a lot to learn. But I remember back, it's one of the most biggest learning curves for me was how do I explain things to patients and their families? How do I listen? And that was the big learning curve that I remember thinking about in those first couple of years out of medical school. I recognised that was something that was the most challenging for me. And the more years from that time looking back, it just re-emphasises again and again how important that listening, how that communication is, and we often talk of it as a non-technical skill, communication, but it is so important, and it is. We do need to practice it. We need to practice, and we need to live it, and we need to practice it, and we need to reflect on it.
What practice techniques have you found most useful with developing those skills in yourself?
I think having a mental model of how to communicate gives me a tool that I can practice on, and observing others is another way that, so seeing what is exemplar practice is a very powerful thing to reflect on, to see what's really good, and to see what's not good gives you some benchmarks to say, what should I be doing? And hearing the consumer perspective and the impact of when things go well or don't go well is a really powerful reflective force for me, I find, in my own practice.
Mm-hmm. I'm curious to know about how your work with Ryan's Rule, you mentioned that earlier,
Yeah.
how that interacts with this particular standard. I imagine that there is some elements of the calls that you get that relate to this standard.
Yes, so Orion's Rule in its purest form is a safety mechanism to for patients and families to communicate when they feel they haven't been heard. So it is a core element of communicating for safety. It gives patients, family, a mechanism to raise issues. Orion's Rule is actually putting around saying a response needs to be done in a timely fashion. So what do I find? I find myself the communication with the patient or the family member who's raising the concerns. Often, for me, it's listening to those. It may not be actually finding the solution. I may actually have to then do my clinical communication with the treating team that are looking after it, and asking for and discussing the issues with them, and working out a plan with them so that response happens. So and then that clinical team are meeting with the patient and their family, and that circle is really then completed. If the concern has been raised by a family member, the urgent clinical review is a really important thing, but equally important is that call to the family member who may not be in the hospital to tell them what's happened for them. So it's a full circle in terms of communicating for safety, where multiple members of the team, including the patient and the family, are part of that response. And that, at its best, that is what Ryan's Rule is set up to do. Communicate for safety.
Fantastic. Belinda, coming back to what we were talking about earlier with just walking into a clinical space and being able to identify the difference between communicating for safety done well versus not, what are your experiences around that?
Over the years, definitely seen both sides of the ball there. It's when you come in and you have somebody who asks you first. They ask you questions first and they want to hear from you. That quite often indicates to me that the person is interested. And then there were others when you walked in and they were like, okay, I've got this information here about you, but I don't know you and I don't know your case, and I know you've been doing this a long time. Tell me what's concerning you today.
I'm interested, I know for myself, having had experiences with family in, receiving healthcare. Joel, how do you go with family or yourself, in those environments you walk in, you're maybe in an ED or in a procedural setting, and you're seeing, I guess, communication breakdowns or procedures and things that, wouldn't pass auditing standards. How do you manage that for yourself? How do you reconcile it?
You do feel vulnerable. You do feel vulnerable. And anything that can empower you or your family to speak up, and we've heard examples of speaking up and innovative ways to provide information. Anything that promotes confidence to ask questions, anything that promotes a listening ear, is good, has got to be good. As a patient, I probably feel I have an advocacy role, not only for my health, but for my family's health and possibly for other patients. And I think that raises the importance of. I'm going to put my medical administrator hat back on for a minute, because it's raised another thought in my mind about the importance of complaints. We think of them as a bad thing, but they're not a bad thing if they're treated seriously, because this opens a window to say, how can we do things better?
How is it that we can make this a more positive experience for people and frame it in a way that it helps them with their practice, rather than it becomes that big stick or that shadow, big brother looming over them?
Yeah, that's a really good question. And I think the answer, there's multiple answers to that. I think there is definitely an organisational responsibility, but equally there's an individual responsibility, and the power of an individual to role model and to influence people around them, I don't think we can underestimate.
Quite often, like you say, people come to work, particularly healthcare workers, to do the right thing and to help people. They're not there going, I'm going to do a really bad job today and I'm going to make sure that person over there gets sicker. Sicker, what a word. But so it's like when you're making a complaint from the patient's side, I think that it's important to take away that blame thing and actually put the facts out. Because when I get up in front of an executive team or something and I tell them about an event that's happened in their hospital, and I say to them, I give them a step of facts. They can't argue it. They can't go, oh no, he didn't do that. And he can't stand and go, oh, you're making this about me. It's not about you. It's actually about the system and what happened there. For example, we were talking about violence in the ED, and people being the team being abused by people. And I said, well, last week I took Mum in, and I went through step by step from actually trying to get my mother from the car, who's disabled in a wheelchair, from the car in a 2-minute park and into the emergency, then having to leave her for nearly half an hour to go and park my car, having a bad note written on my windscreen telling me I was going to get towed away because, I hadn't moved it in 2 minutes. So by the time I actually got out the back with Mum, then we went through all this, and she hadn't had her night medications and she gets bad pain. So I was asking after and after and after, can Mum have her pain medication? Can this happen? And I kept getting told, we'll check. So 4 hours goes past, Mum's in pain, and I'm like, this is ridiculous. So I just pulled her tablets out because I had them there, and I just started giving her tablets like I would normally at home. All of a sudden I had this rush of people around me. Oh, what are you doing? You can't be doing that. I said, well, nobody else is giving anything, and Mum needs these. She's a diabetic. She's got this, and this, and she can't be here not having had this medication. I need somebody to approve it, or I'm just going to give it to her. And I got angry. I got upset. If I was an abusive person, would have been abusive. Because it was late, I'd had a full day at work, I'd come home to Mum collapsed, all these things had happened. And I said, I'm not that person, but I became that person that night because I was just so frustrated and so worked up at what was going on in an already heightened environment. And I said, this is where we need to be thinking about those little things like, how do I get my mum from the car when there's no call alarm? How do I deal with this? What can the hospital do to make that process just coming in the door a little easier? So
it's so important, Belinda. And from what you've told me today, you are such a powerful advocate for consumers, and we really appreciate the work that you do and the voice that you are.
Thank you.
Joel, anything you want to add before we sign off? Is there, just in terms of advice for people, or something that you typically see as an auditor that people are often getting tripped up on during the process of accreditation? Anything?
One message would be identification, identification, identification. And I say it 3 times because it is important. Patient identification is so important. I say it 3 times because accreditors are looking that we use 3 patient identifiers, asking patients their name, asking their date of birth, checking their UR number, or asking their address. And accreditors, when they come and observe our handover, they will be looking to see, are we using patient identification? So that's a key message that we need to keep front and centre in our minds and in our practice about the importance of identification.